So if I show you a choledochal cyst on, let's say, an MRCP, you will immediately pick it up. On the other hand, if I show you the same choledochal cyst on a CT scan, you will be struggling to see it unless you stretch your imagination. So these kinds of things I'll show you in examples. Now, contrast studies, as in bariums, they are important for the exam. Now, why I say important is that your chances of getting a contrast study, I'm not saying all of you will get a contrast study, but you might get a contrast study. So, I know that the current generation, you people you don't have experience. Wherever I go in the world, I ask everybody, and I think contrast studies, for obvious reasons, have gone down. So it's a weak link for you, and the examiners know it. So still, contrast studies are asked in the exam, and I am going to show you a lot of contrast studies intentionally. You are very good in CT, but you are not good in contrast, so I will concentrate there. And this is one point where we will, I'll show you many cases. Many cases which I'll show you, particularly on contrast, is just for pattern recognition, Aunt Minnie type of cases. Once you see them, that's it. But if you don't see them, then, you will struggle. So I will show you many cases for pattern recognition. Important differential diagnosis from Chapman. I'll be following Chapman 7th edition. Right. So, can I ask candidate 1 to raise your hand, please? Can you do that again, please? Because there is a technical issue for me. I could not. Just bear with me. Yeah, now I can unmute you. Are you listening to me now?
Yeah, hi.
Okay, this is a MRCP study. I have given you T2 axial sequences and intentionally just the axial sequences. And what is your diagnosis?
Okay, so in the selected images available, there appears to be a filling defect in the left portal vein.
Anything else, please? Hint, it is too obvious. Hint, if you see a CT scan, you will pick it up in 1 second.
Okay, so I can't see any focal hepatic lesions. Is it generalized hepatic steatosis?
Okay. So what was that?
Air.
Air. So this is pneumobilia, isn't it?
Yeah.
So the point which I am making is that if you go back, you see there is pneumobilia here. But the eye see what the mind knows, because on a T2 weighted sequence, you have not seen it. So you found it very difficult. On the other hand, on a CT scan, it was very, very obvious. So this is an example, and I'll take it further on this, where you have to, I use the word, you have to stretch your imagination, right? And you will find everything very easy. So candidate 1, you can keep yourself unmuted, but in the first, let's say 10 minutes or so, it's going to be more of a lecture type of a mode. But there are any questions I'll ask you. There are no films.
Okay.
Now, you see, on your slide, there are 3 types of contrasts, and the concepts about these contrasts are very important for the exam. And this is the difference between a safe radiologist and an unsafe radiologist. It's a black and white thing. If the examiners find you unsafe in the exam, you will be penalized for it. And that, you might fail because of that. So the point is, barium, gastrographin, and low osmolar contrast agent can be used in GIT, right? So, take home points for esophageal perforation, use low osmolar contrast agent. If you use barium, what happens is barium goes out. For example, if the barium goes into the mediastinum, later on it will sit there. It might cause fibrosis. You don't want barium to, if there is aspiration, you don't want it to go into the lungs, where again it can be, it can remain there and cause fibrosis, etc. Though it is not as dangerous as gastrographin. So point to remember that gastrographin, if it goes into the mediastinum, there is a esophageal rupture, no issues. But if it goes into the lung, oh, that is problem, because there will be, you will produce pulmonary edema. So the best thing is to use low osmolar contrast agent. Now, if you see here, this is Visipake. There can be many, Omnipake, etc. And on some of them, if you see the word oral use is written there on them. So they can be used intra-arterial, intravenous, as well as oral. Now, for upper abdominal GI perforations, you can use gastrographin. So sometimes what happens is, if the perforation is not visible, we can use gastrographin, particularly, let's say, a post-op case, surgical anastomosis leak and things like that. So here, if you say barium, it's a blunder. You are unsafe. So remember that. You have to use gastrographin there. Now, another use of contrast agent is for equivocal small bowel obstruction. So you can use barium, but these days, most of the people, they use gastrographin. And one of the techniques which is written here is from one source, but there are so many other techniques. My experience with gastrographin is that if there is too much fluid in the bowel, the gastrographin might become diluted, and then it is not all that effective to diagnose subacute obstruction. Barium, on the other hand, will not be diluted. Please also remember that there is no concept of barium converting an incomplete obstruction to a complete obstruction. There was a lot of debate in, let's say, 30, 20 years ago, where surgeons used to say that barium can convert a incomplete obstruction to complete. Our literature does not agree with that. Gastrographin, some people think, is sort of therapeutic also. Again, controversial, but some people think like that. So both of these you can use. Now, as far as large bowel obstruction is concerned, for equivocal large bowel obstruction, or you can use gastrographin. For pseudo obstruction, I will tell you what is pseudo obstruction. Again, you can use gastrographin. For post-surgical use, you can use gastrographin. Now, post-surgical is a very important thing. Never use barium once again. So please remember it like this, that if the contrast you are worried that it might go out of the lumen, don't use barium. That's the take-home point. What is pseudo-obstruction? I'll come back to this. As far as acute abdominal series is concerned, when a patient comes to A&E, we do a supine X-ray abdomen, and we do a PA erect film. On a PA erect film, gas below the diaphragm is better seen. Classical teaching is that the patient should be in an erect posture for about 10 minutes time before you should take a film. But in the real world, I think we just take it. And so this is an erect film and this is a supine film. Please also remember that previously, because now is the world of CT scanning, so our threshold to do CT scans is extremely low. And previously there were multiple films which were taken. Having said that, examiners still can grill you on those films. And the scenarios which they will give you is, for example, you will say, I will do a CT scan. They will say, what if the CT scan is not working? So classical exam question is, this is a patient of, a suspected patient of pneumoperitoneum. The patient is not well enough to stand. The patient cannot take an erect chest X-ray. What will you do? This is a classical viva scenario. You will say, I'll do a CT. They will say, no, CT is not working. What will you do then? So the answer to that is decubitus film. So this is how a decubitus film is taken. And this is, the liver has to be upside, so the left side down decubitus. And the concept is that the free air will be in between the lateral abdominal wall and the liver. Now, what is the use of an erect film? Now, this is from the guidelines of Royal College of Radiologists. There was a booklet at that point, 2007, which says that consider erect film if supine X-ray is normal or there is strong clinical suspicion of obstruction. Now, erect film, when we were, 30 years ago, when we were learning radiology, there was so much literature on erect film, and volumes were written on erect film and how to diagnose intestinal obstruction, etc. That concept you should still know. In your real world, you will never use it, particularly in UK, for example. But having said that, in the exam, you should know that concept. What is erect film used for? So, for erect film, the main role of erect film is intestinal obstruction, and I will come back to this. I also want to introduce you here to a tool, which is a beautiful tool, iRefer, produced by the RCR. It is available for members, and basically there are algorithms there for various kinds of clinical scenarios, and examiners will ask them. Please remember, they ask these questions, and between the line, there are many things written here which they might ask. So let's go through as far as acute abdomen is concerned. This is G14 in your iRefer, acute abdomen with suspected bowel obstruction. And they are saying that you should do CT or X-ray. X-ray may occasionally be helpful in limited cases of large bowel dilatation, such as known sigmoid volvulus or ulcerative colitis with suspected megacolon. Both of these are classical viva questions. Remember this. Both of them they will ask you in the viva. Sigmoid volvulus take-home point is a plain film diagnosis. And the examiner is going to ask you, once you diagnose it on a plain film, what will you do next? And your answer will be, that's it. As far as imaging is concerned, you will just tell the surgeon that this is your diagnosis. There is no role of doing a CT. You should be confident enough. Secondly is toxic megacolon. If it is a known case of ulcerative colitis, your eyes should pick it up. Having said that, in the real world here, CT can be done because, an associated perforation, etc., can be picked up on CT much better than an X-ray. But these two questions are exam questions. So, of course, CT, the threshold is very low to CT. What is the role of contrast enema? Water-soluble contrast enema is an alternative if CT is inconclusive. So, of course, water soluble enema means you are targeting the large bowel there. So, all of this, whatever is written here, I urge you to read carefully, and each line can save you in the exam. Now, this is acute small bowel obstruction confirmation and assessment of level. So, what is X-ray? X-ray may show if bowel obstruction is present, but cannot exclude it or determine the underlying cause in most cases. So the maximum an X-ray can do is there bowel obstruction or not, but the level or the cause might not be picked up. CT is much better there. Having said that, look at the role of contrast studies. If suspected small bowel obstruction due to adhesions, I will come back to this point, adhesions. A water-soluble contrast study is a good predictor of resolution without operation. Now, this concept is asked in the exam. Now, please remember that the most common cause of small bowel obstruction are adhesions. Number one, concept number one. Number two, 80% of them might resolve themselves. So there is a role of what we call, monitoring the case. And for that, if you do a water-soluble study, gastrographin, if it passes through, then means that there is no need of surgery. Now, next, MRI may be considered in pregnant women avoiding ionizing radiation. Important concept. Again, can be asked in the exam. Then, ultrasound is helpful in gasless abdomen. So, there are many conditions in which a patient can have a gasless abdomen and have intestinal obstruction. So ultrasound can be useful so that it will give you, the loops of the bowel will be full of fluid and you can pick it up. And similarly, it can be very useful in children. Again, it can be a viva question. And ultrasound can also help to see if there is peristalsis in order to differentiate between, functional ileus or obstructive ileus. These concepts are extremely important. Now, so this is a potential exam film. The examiner can show you a film in which there is gasless abdomen, but the clinical will be the patient has got acute symptoms. So these are the causes of a gasless abdomen. Fluid-filled bowel is what we are talking about. So the patient has got complete obstruction, but it is full of fluid. That's why there is no gas. So remember this. And finally, again on the RCR, I refer small bowel obstruction, low grade or intermittent. And here, intermittent means what we call subacute. Low grade, intermittent, subacute, all are words which can be used interchangeably. And what happens is that you can do other kinds of studies like CT enterocolysis and CT enterography, MR or MR. I will come back to these when we will cover small bowel. Okay, ST1s after the exam, which is after October, we will go into a phase where we'll go back to the basics and go back into details. So today, for example, I'm not going to teach you how to read a X-ray abdomen. All ST4 know it, but I am sure ST1s don't know it as well. So we'll go back and we will design some curriculum for ST1 level. So this is the protocol to see a plain abdomen. A few measurements for you to remember, and what are the criteria for various parts which are here. One thing which I want to emphasize is pseudo-obstruction. Now, pseudo-obstruction is an entity which you will see in old age patients, and these patients will come to you with, horrendous-looking plain X-rays, and you will see on PACS old films, which will tell you that this thing was there since ever. And these patients are usually bedbound. They might come to you from care homes, etc. And all of these rules, they don't stay, they don't hold for them. And up to 22 centimeter bowel is reported, dilatation. So these, I will, all of you, I think, know these, but this was just for revision. Okay, key exam tip. Key exam tip is, most important exam tip about plain abdomen is, when you see a gas focus on the plain abdomen, ask yourself, is it in the bowel? Is it outside the bowel? And very, very important for the exam, is it in the wall? Is it in the, what we call mural? And again, cases will come in this category. So within the bowel, it can be within the stomach, small intestine or colon. Outside the bowel, it can be under the diaphragm, it can be within the liver or any other viscera, it can be in the bile ducts, the portal vein, there can be pockets of free air, it can be in the retroperitoneum. All of these are exam cases. And these are again exam cases. So here, the gas is present, but this gas is present in the wall of the viscera. And again, they will come in the exam. Is it in the bowel loop, or in the stomach, or urinary bladder, or gallbladder, etc. So I'll show you examples. Now, another exam tip is, when you are describing anything like an intestinal obstruction type of a case, you have to tell the examiner, number one, which segment of bowel contains the gas. Number two, is the caliber or dimension of the segment more than what is allowed? Number three, what is the distalmost point the gas has passed in the intestine? So is there any gas in the rectum? This should be part of what we call pertinent negative or positive. So it should be part of your description. There is gas in the rectum or not. Please remember the concept that when there is a complete obstruction, it takes about 24 hours or so for the gas to absorb distally. But after that, there might not be any gas in the rectum. So it becomes an important pertinent point, though the specificity is quite low. This is extremely important for the exam, and it is important even for your rapid reporting, because there is a case which comes again and again in the exam, and which is toxic megacolon. And here you can see the mucosa, outline of the mucosa of the transverse colon. So I will show you the examples. Okay, so with this background, candidate 1, your film. Patient has got acute abdomen presentation. Over to you, please.
This is a frontal radiograph of an adult patient. There is a tubular gas-filled structure in the midline, which would be in keeping with the transverse colon. The mucosa of this bowel looks a bit inflamed, and I would consider colitis as part of the differentials. I can't see any fluid.
Okay, good. Now, you have inferred that there is colitis, and you have said correctly that the mucosa is inflamed. This is your inference. But on which grounds? I want to hear that descriptive, should I say, those descriptive terms. You have concluded correctly, but how have you concluded that?
So the mucosa appears a bit irregular and thickened compared to usual. Mm-hmm. And the irregularity combined with the abnormal thickening.
Okay, that's fine. I'll take over. So if you see here, normal transverse colon has got Hofstra, and this thing should be in your mind, in your description in the exam. Loss of Hofstra. Remember that. The loss of Hofstra. Number two is, if you see, these are thumbprints, right? Lots of fostra, there is thumbprint here, and maybe a pseudopolyp. So the point is, let me show you another case. Rather, these are two different cases. Again, you will see that there is loss of fostra, complete loss of fostra. This is known as thumbprinting. And this thing which is projecting into the lumen are known as, these are mucosal tags, simple as that. So, but this is evidence that there is mucosal thickening. So you will say loss of fostra. If there are thumbprints, there is thumbprint in keeping with mucosal thickening, and there are some, filling defects within the air-filled lumen in keeping with inflammatory polyps. Now, if you see here, megacolon in an adult, so non-toxic without mural abnormalities. Toxic is with severe mural abnormalities. And these cases have come in the rapid reporting, many a times. For example, this is a classical rapid reporting case. It can come in the viva also, whatever. So you have to really develop your eyes on this. And loss of fostra is one of the key things which you have to remember. What's happening here? I just want to hear a radiological sign.
Is it called the string of pearls?
No, if you see here, stretch of imagine, this one, this one, this one, this one. Thumbprinting, once again, it's thumbprinting. Now, interestingly, this differential was there in the previous editions. Thumbprinting is, I just wanted to show it to you again so that you know that this word, it should be in your vocabulary, should I say. And the point is that many things, it's a non-specific finding. Non-specific finding of what? Because basically mucosal thickening. And this mucosal thickening will be seen in the large as well as the small bowel. I'll show you many examples. Please do not think that all cases of mucosal thickening will have thumbprints. Within the small bowel, there might be other signs which we will consider later. You are in the A and E. This patient comes to you from the hospice. The patient is not very well oriented. A bit of dementia is also there. You have done this X-ray. What are your comments?
Okay, so this is a frontal radiograph of the abdomen in a 92-year-old patient. There are multiple large dilated bowel loops with an abnormal position. There's a large tubular structure which projects to the left and lacks ostrations. My first differential for this will be a sigmoid volvulus. I can't see any free air or gas. The patient still has an intrauterine device, I think, in the pelvis. So in summary, this looks like it's a sigmoid volvulus as a most likely diagnosis.
Why do you say sigmoid volvulus?
I can't see the ostration patterns in the large dilated bowel loop. The axis appears to project more to the left, and it's more common than cecal volvulus in this, and especially in this age group, and in a hospice patient. So with the clinical information.
Okay, your main reason to call it a sigmoid volvulus was that you thought, let me point out, hostra. If you are worried about this loop, there are hostra. If you are worried about this loop, again, there is hostra. And in a sigmoid volvulus, what will happen? This will be a U like this with two loops. The U is not there, inverted U, I mean to say. Anything else?
It could be an ileus.
What will you do next?
So, if they're concerned and the patient has acute abdominal pain, I'll recommend the CT.
right? But before that, CT is the correct answer. But first thing which they want to hear is, I will compare it with the previous films. You know, this kind of a scenario where a patient comes from hospice, it's not an acute scenario. These patients, and in your day-to-day practice, you will see them so often if you're working in A&E. You open a previous PACS film and the abdomen will be like this. I'll come back to this point. So this is the CT scan. Unfortunately, I have not given you, the, let's say, recto-anal canal junction is not there. Having said that, everything is dilated. There is no pneumoperitoneum in this case. What will be your conclusion?
So it looks like there's fecal impaction of the sigmoid colon. The sigmoid is quite dilated with upstream dilatation of the bowel, but the bowel wall continues to enhance normally. I can't see any free gas in the abdomen. So my main differential is the sigmoid fecal impaction or fecoma.
Okay, so impaction. In these cases, two things are very important. One is anal canal cancers. You have to ask the clinicians to have a look. That's a clinical territory, right? They can have a look. The patient might have an anal canal tumor, which is causing stenosis. So that's a potential viva scenario. Otherwise, in this particular case, there was no anal canal or anything. This is a case of pseudo-obstruction, chronic pseudo-obstruction. And pseudo-obstruction, as I told you before, we'll see in cases where, bed-bound hospice cases, things like that. Because of chronic constipation, they are like this. If you compare it with the previous film will also be like this. And every 3-4 months, they might be coming to your A and E. And in these, the criteria for dilatation is different, as I told you in the table. Up to 22 centimeter has been documented. Having said that, sometimes these patients can also perforate, and I've seen a few where, don't think that it's a completely benign condition, and there will be a time when they will perforate. But the concept of pseudo obstruction should be in your mind, and this is, this thing, chronic pseudo obstruction. And in UK, this is a very important concept, particularly in A. Okay, candidate 1, this is your last film. Acute abdomen, pneumoperitoneum, yes or no?
No.
So what is it?
Chiodati syndrome, where you have a part of the flexure projected over the liver.
Okay, that's fine. Now, here what is happening, and this film can be shown to you even in rapid reporting, just to confuse you, where some people might pick it up as pneumoperitoneum. Now, this is what we call interposition of large bowel in between the diaphragm and the liver. And the key thing is that the haustra will be projecting in. Okay, thank you very much, candidate 1, and we go to candidate 2, please. Raise your hand. Candidate 2. Okay, I cannot see candidate 2, so I will go to candidate 3 then. I am unmuting candidate 3. Candidate 3, can you hear me?
Yes.
Okay. This patient has got, are you worried about intestinal obstruction in this case? Which loops of bowel are visible? These are my 2 questions.
think these are dilated large bowel loops.
Mm-hmm.
I think the caliber of the bowel is within acceptable limits for large bowel. Therefore, I am not worried about obstruction.
Right. Now, if you go back to the basics, this is a very tricky film. Actually, you remember, how do you differentiate between small bowel and large bowel loops? Picture frame is why you are confused in this case. Picture frame is one thing where large bowel loops are at the periphery and small bowel are in the center. Then is Hostra versus Vulvuli conjunctives.
Mm-hmm.
And these are Vulvuli conjunctives. These are not Hostra. So that's the key thing. And they are really dilated. And if you see here, this is small bowel. Actually, there might be something here, but if you see, there is nothing in the rectum. So beware of severely dilated gas-filled small bowel. And the teaching point or learning point is to differentiate between vulvuli conjunctives versus Hostra. The same case, I am showing you erect film. As I told you, there are no chances of you getting an erect film. But if an examiner asks you this question, this film will help you. So, how will you describe candidate 3, this film? You know, this is the same patient, by the way.
So there's quite marked opacification in the mid to lower abdomens, with almost like a fluid level visible across the bowel.
Excellent. And what is this where I am pointing out?
Looks like gas within bowel. So
there is a sign. I'm waiting to hear that sign. And that sign is considered quite specific for intestinal obstruction.
I'm not sure.
Okay, fine, no problem. Now, on an erect film, what happens is that you will get what we call fluid levels or air fluid levels. Air fluid levels. There is a lot of literature on this, so I don't want to go into that. The only thing is that this is known as string of bead or string of birds, string of pearl sign. Now, this is another patient, by the way. This is not the same patient, but just to emphasize, let me go to, okay, there will be another film where I will teach you once again. What happens is, string of bead or string of pearl sign is an exam sign of intestinal obstruction. Basically, when there is significant amount of fluid filling of the obstructed bowel loop, there is limited amount of gas bubbles. Now, these gas bubbles are in between two vulvuli conjunctives. So they will give you this kind of appearance. This appearance can be seen on an erect X-ray, or it can be also seen on a CT scan. And when you see it, call it. It's considered quite specific for small bowel obstruction. And this, whatever is on this slide, there are a few viva questions which have been asked in the exam. As I told you in the beginning also, adhesions are the most common cause. These are the causes which you have to remember. Again, this is a viva question. Adhesion 60% is the most common cause. Please also remember the concept that 80% of them might resolve. So this is important. And this is another case from literature, from StatDX, to give you the same concept. This is a supine film. This is an erect film. And on supine film, things look quite normal actually. Well, what is this? You know, if you report it, you will not be much worried. But when you do an erect film, then you pick up this string of bead sign. This tells you what is happening. Actually, there are dilated loops of small bowel and trapped air bubbles giving you this appearance in between the vulvally conventives. And this is the CT of the same case. And it tells you this string of bead or string of pearl sign. So this is important to remember. Okay, candidate 3, your film. This patient is 57 with constipation. Can you tell me which loop of bowel is this? Anatomy-wise, small or large bowel?
It looks like large bowel.
Excellent, well done. So these are hostra. So this is large bowel. Is there gas in the rectum?
I can't see any gas in the rectum.
Excellent. So what will be your conclusion here?
I think these findings are concerning for sigmoid volvulus.
Okay, but why did you say sigmoid volvulus? Because please remember, sigmoid volvulus, the margins will be without hostra. There are very limited hostra, 1 or 2 in sigmoid, and when it is dilated, even those are not seen. So remember, it's a very important point for your exam. Apostral margin. This is one of the key things in sigmoid volvulus, right? So this is a large bowel loop, but it is something else. So in this case, we did a gastrographin. And what is your finding?
So there's contrast or pacification within a loop of bowel, which looks like the cecum.
So let me take you through it. This is the rectum, right? And we are going into the sigmoid. Now, as soon as we reach this, this is sigmoid here. This loop is projecting behind it. So what is happening here?
Narrowing.
Excellent. So this is a stricture. And this stricture is in the sigmoid colon. One of the key findings, which are when you do a contrast examination for a suspected, large bowel obstruction, these days we usually use gastrographin. If you use barium, you have to be careful. If you reach a stricture, only limited amount of barium should be allowed to go beyond it, proximal to it. But do you think, what is your final conclusion? What is happening, benign or malignant?
I think this is malignant.
Excellent. And why do you say that?
Because there's shouldering of the...
Excellent, well done. So this is a classical apple core type of a stricture with shouldering and overhanging edges. And this was a sigmoid. So what are the take-home points? The take-home points is that we saw a loop of large bowel. We are not sure which loop, but it has got hostra. So this should not be confused with sigmoid. And actually, there was a stricture there. Okay, this one is for pattern recognition. So this patient is post-cholecystectomy, and I am not worried about this. Is there any abdominal visceral abnormality? Over to you, please.
The spleen looks enlarged.
Excellent. So this is the teaching point here, and this has come in the exam quite often. Because please remember that one of the protocol-wise, you have to look for any visceral, megaly or things like that. And here, this is the spleen. And this spleen is enlarged. So this is the psoas, this is the psoas. And this is the kidney. Part of the kidney might be visible here. But this thing is the spleen. So the CT scan of the same patient where you can see splenomegaly and lot of lymph node. An MR of just to show you the same thing, and plain film of another patient. Though I have written it here, patency capsule, but candidate 3, can you please tell me what exactly is this? What do you understand by this patency capsule? Have you ever seen it?
No, I've never seen it before.
Okay, so let me tell you. Now, these days, to evaluate the small bowel, the gastroenterologist also can do video endoscopy. So they have got a small capsule which has got a video inside, and they ask the patient to simply just, gulp it down, and it goes through the small bowel and produces a video, and later on they evaluate for this. Now, before that, they have to make sure that there is no stricture. So usually they might do an MR enterography, etc., that there is no stricture. But even whatever we say, they will do. This is made up of a radiopaque material which is dissolvable. It is biodegradable, but initially it is radiopaque. So they ask the patient to take it, and then they take plain film, let's say the next day, and it has to go beyond small bowel, and that is a indicator that there is no stricture. On the other hand, if it stays inside, means there is a stricture. And if there is a stricture and they have done capsule endoscopy, then they will have to do surgery because of that. So I just wanted to show you, because in this era these are being used very often, so all candidates should know and the concept behind it. Patency capsule. Candidate 3, over to you. Anything in the soft tissues? Do you see anything?
So frontal radiograph of an abdomen, there is increased soft tissue density bilaterally, but predominantly on the left side of the abdomen.
Yeah. So you have picked this up. Very good. Well done. Now, what is your differential?
It looks almost house.
So it is very rounded, right?
It is very rounded. In that location, it could be a adrenal gland mass, or
so now you are talking about what we call a differential, and your mind is absolutely working brilliantly, because now you have seen that this is kidney. Now the lesion is here. So in this region, your thinking is what is there, and the first thing was spot on. You are worried about adrenal. What else can you be worried about?
So it could be a mass arising from the upper pole of the left kidney.
Excellent. But if you stretch your imagination and see here where I am pointing out, right? Maybe you can see the outline. So good thinking, but less likely. Okay. What else?
Pancreatic lesion.
Excellent. And what kind of pancreatic lesion comes to your mind?
As big as that. So a pseudocyst.
Brilliant, well done. So this was a pseudocyst. So well done, candidate 3. We will go to candidate 4. Well done. If you see, this was the pseudocyst, and you can see that this is what we call the lesser sac. The stomach is here. It is displacing it anteriorly. Well done. Now, candidate 4, can you raise your hand? You are with us?
Yes, sir.
Okay. Now, spot diagnosis. I am not at all interested in all of these radiopaque foci, but overall picture, give me a diagnosis. What do you think about these loops of small bowel? What is happening?
There, I can see there is a obstructive small bowel obstruction, and it shows the regular sign.
Okay, regular sign. So, for example, here you might have picked it up, and if I know there is no regular sign, anything else comes to your mind? Where are these small bowel loops? Where, anatomically speaking, this is the abdomen in cross section, transverse and longitudinal. Anything comes to your mind?
In the center of the abdomen.
Excellent. So, conclusion.
So it's small bowel obstruction with the yes,
I like that when you said that they are in the central part of the abdomen. So,
yes.
hint is that I like that. What comes to your mind?
So it's just a small bowel obstruction, which in the center of the abdomen. And what else? No. What? No, I'm not getting that.
I'll take over. Don't worry.
Yeah.
This is ascites. Now, this kind of ascites has come in the exam. I remember there was a long case actually. Can you imagine a long case which came, I think 2 years, 3 years ago? It was a baby gram. And on that, one of the key finding was that this was the finding on a baby gram. Sometimes what happens in ascites is that because there is too much fluid, the small bowel loops, which are gas filled, they float centrally. And this is the picture which you get, floating small bowel and centrally. This is another case where small bowel loops are here in the center. And this CT scan tells you what actually happens. There is a lot of ascites and these loops are in the center. So I'm not saying that all cases of ascites will look like this, but you have to remember, as I always say, the eyes see what the mind knows, that this type of ascites can be asked in the exam. Okay, candidate 4. Anything abnormal here?
Okay, that's the erect abdomen in which I can see there is a continuous diaphragm sign.
No, don't worry about this.
Okay, so
anything in this?
There is a soft tissue mass I can see in the epigastric region.
Okay, you look carefully. Of course, maybe the projection is not very, very clear. But having said that, you have picked up this thing, right? What comes to your mind? What can you describe it?
Yeah, there is a soft tissue opacity and the left under the left heparin diaphragm region, which is irregular in margins. It's not. I can't see any calcification in it. It's located in the area of the.
Okay, so this I'll give you a very interesting hint. I think this is from BMJ, and this is a case report. This X-ray was done at Heathrow Airport, and this patient, according to that case report, was then spending time in Chelmsford jail. Now over to you.
Ampules.
Yes. So if you see here, this is a body packer or a drug mule. So what they do is that they use, either they use latex gloves. For example, these are fingers, of the latex gloves, which are tied together. So what happens is that the beam of X-ray, if you see, it gives you a crisp and sharp outline where I am pointing out. this is the outline of it, or they can also use condoms. So this is what they do. This is body packer, and this is another case from literature. And this is, we also call them drug mules. And this is a better quality picture, which gives you the same appearance. Look for this. It's a very, Aunt Minnie type of. If you see it, you see it. And if you don't see it, you've never seen it, you will never pick it up. So it is another example.